Good day, colleagues, and thank you for joining us. I am Dr. Shanti Singh Anthony, Knowledge Management Coordinator for the Pan-Caribbean Partnership Against HIV and AIDS. Special welcome to all of you on behalf of my director, Dr. Rosamond Adams. This is a PANCAP webinar in collaboration with UNAIDS, PAHO, and the Caribbean Vulnerable Communities Coalition. As of yesterday, May 7, the World Health Organization has reported a total of 3,672,238 confirmed cases of COVID-19 and more than 250,000 deaths due to COVID-19 disease. In the last 24 hours, there were more than 83,000 confirmed new infections. We are all impacted, but there is growing evidence that the marginalized and vulnerable are at greater risk for COVID-19. Today's webinar will focus on the importance of maintaining a human rights-based approach to the HIV response, as well as practical strategies for governments, civil society, and people living with HIV to ensure that people's health, well-being, and rights are upheld during this crisis. Inherent in this approach, we will focus on the need for continued community service delivery of HIV prevention and treatment services, and leveraging our community systems to support the COVID-19 response. Before we proceed, I'd like to note a few housekeeping points. Firstly, your mics are muted. If you have any question as the presentation progresses, I ask that you type these and submit these on your webinar menu. We have two presentations today. We'll take both presentations, and this will be followed by a question and answer segment where we'll address the questions that you submit. Second, the webinar is being recorded. We will post the recording on PANCAP's website and social media platforms for the benefit of those who are unable to participate at this time. At this point, I'm pleased to introduce to you Cedrian Martin, our moderator for today's webinar. Cedrian Martin is the Communication Advisor for UNAIDS Caribbean Sub-Regional Office based in Kingston, Jamaica. She is a former journalist from Trinidad and Tobago. Over to you, Cedrian.
Thank you, Dr. Singh, and welcome to all of our partners who've joined us online. I am safe and sound in my living room in Trinidad, and so pleased that we could all connect to think through how we could address some of the challenges we're encountering. In one way, we're in an unprecedented situation in terms of the social and economic disruption caused by the COVID containment measures in the Caribbean. But in other respects, I think HIV response stakeholders are in familiar territory in terms of balancing attention to health, social, economic, and human rights needs when responding to an epidemic. Today, we'll hear from two experts. The first is Dr. Cesar Nunez. He's director of the UNAIDS Regional Support Team for Latin America and the Caribbean. He has more than 20 years experience in managing HIV and international public health programs. He's a former director of the National AIDS Program in his native Honduras and has served as the deputy director of the PEPFAR USAID Regional Program to strengthen the Central American HIV response. And we'll also hear from Mr. Ivan Cruikshank, executive director of the Caribbean Vulnerable Communities Coalition. He has over 20 years experience in various aspects of HIV programming with intimate knowledge of human rights and the community-based response to development. He currently chairs the Jamaica Country Coordinating Mechanism, the National Technical Working Group for an Enabling Environment and Human Rights in Jamaica, and the Equality for All Foundation. So we will have the two presentations before we move into a question and answer period. And I would first hand over to Dr. Nunez.
Good morning, Cedrian, and good morning, Dr. Singh. It's a pleasure for me to be here today and in the company of Ivan, and sharing with you about this very important topic as we move through the pandemic that has taken the world in the past few months already, as unbelievable as it is. As Cedrian shared a bit ago, I am also not in Trinidad, but I am in Panama City from my dining room, and I will kick in right away. In this presentation, I'll share with you 5 principles for achieving a human rights-based HIV response in the context of COVID-19. And then I will also share some practical strategies that could be useful for, of course, civil society and people living with HIV, but also to governments to make sure that that health, well-being, and rights, above all, of all Caribbean people are upheld during this crisis, and that HIV response gains are not lost. Some of you may have known UNAIDS, Rocatari. Some of you may be aware that in early April in Belize, Ulysses was arrested for breaching COVID-19 curfew laws. He was a 29-year-old gay man, fashion designer, and while in custody, he suffered homophobic slurs and bullying by police officers. We know this for sure because a video of the incident was posted to social media. Ulysses claimed he was also physically attacked, resulting in a visibly swollen jaw. Days later, he died. Our starting point for this discussion is that the public health measures being taken to combat COVID-19 are not an excuse to violate human rights and people's right to dignity. We must be vigilant that during the COVID-19 response, we do not undermine or sacrifice the right to health, the right to privacy and confidentiality, the right to liberty, the right to non-discrimination, freedom of assembly and expression, as well as the right to information. You may have heard or read from some governments in the region, and how some of them have even split the quarantine or the mandatory quarantine by gender. And that is also something that has created significant challenges, particularly for LGBTI communities. For COVID-19 containment efforts to work, there must be trust, and I underscore the word trust, between the communities, the government, and health officials. And of course, we have to actively encourage an environment of solidarity and kindness for all. Solidarity, it's a word we hear a lot in the news, on the radio, on TV, but we do not get to see much of it in the actual flesh and blood. In Jamaica, for instance, family members of patient 0 received death threats. Nurses have reported being barred from public transportation, and some patients have given health authorities wrong addresses to avoid the stigma that a home visit would attract. We will not combat either HIV nor COVID-19 with only tests and treatment. Success will rely upon generating a sense of unity and compassion, and certainly acts of discrimination undermine our efforts and must not be tolerated. All our actions can be rendered ineffective by ignoring existing inequalities. We have to prioritize the most vulnerable and empower people to be able to take action to protect themselves and others from the virus. And we have a lot under our arms in terms of the response to HIV during the past years. In the picture, you will see these migrant sex workers that were held under public health novel coronavirus regulations at a guest house in Trinidad on April 10th, 2020. Throughout the Caribbean, how have we addressed the challenges people like them face? When groups are excluded from COVID-19, social protection responses, they are forced to put their safety, their health, and their lives at increased risk just to survive. And we know that many families are hurting today, and it's easy to forget those who are on the margins due to factors like poverty, homelessness, drug use, sexual orientation, gender identity, and yes, also migration status. our region has been facing a large migration challenge since for the past couple of years, and COVID has become a compounding factor. Our response to COVID-19 must be grounded in the realities of people's lives and focused on eliminating the barriers they face in being able to protect themselves and their communities. We have to respond to the widespread loss of livelihoods and to whether people have enough food. We know that many of the most marginalized and vulnerable make a living through the informal sector and may not have sufficient access to relief from state. What is the proportion of informal sector jobs in any given country? Is it 3 out of 10, 4 out of 10, 7 out of 10? You can make the calculations of how much that impact will be when we have countries with as many as 7 out of 10 jobs in the informality. And that is why community organizations must be involved in COVID-19 response, planning, and rollout. They need to have a seat at the table. They must be included, respected, resourced at the same time. In the image, you see Dolores Robinson of the community organization Groots TNT. Without structured funding, Groots has been providing nutrition support to 30 families. This picture shows her delivering food to 7 children in the low-income community of Ceylon, where their HIV-positive mother is hospitalized. Think about how many people are invisible to formal systems and would be neglected but for the work of community organizations. There are valid concerns around antiretroviral treatment stockouts and supply chain management that must be addressed in the Caribbean. Yes, production factories in India and China have been either closed or are just reopening, and that's where most of ARVs coming our direction are made. Adopting the WHO guidelines for multi-month dispensing will allow people to maintain uninterrupted treatment regimes without risking increased exposure to COVID-19 when retrieving their medicines. I personally wrote a letter to every Minister of Health in Latin America and the Caribbean, asking and arguing in favor of multi-month dispensing. But COVID is going to have a much stronger and robust response if we have a strong health system and if we have been on the preventive side of the response as well. But as urgent as priority this is, for many Caribbean people living with HIV, it is not the most pressing concerns. I have heard about loneliness, exclusion, bullying, taking toll on those who are either living alone or forced to share hostile households. Already abusive domestic situations are becoming explosive due to increased stress of COVID-19. Community organizations will play a key role in supporting both treatment adherence and mental health during this time. And these organizations should be included in contingency planning and implementation process to ensure continuity of treatment and care. Now, how do we achieve this? HIV stakeholders bring to this experience almost 40 years, as I was saying, of wisdom in responding to epidemics. We know the importance of a human rights-based approach. We have said it all the time in order to ensure effective and proportionate responses. So let's try to follow the guideposts from a historic global response to make sure that we have a proper response to COVID-19. For governments, first of all, and I have said that already in several of my previous slides, governments must ensure that in developing the response, communities are at the governance table and part of a team determining suitability and effectiveness at all stages. If this was done from the start, it must be done immediately. If this was not done from the start, it must be done immediately. While human rights allow for the limitation of some rights for legitimate purposes, such as to protect public health, here we're talking about the quarantines, there are strict boundaries on when, how, and to what extent rights may be limited. Any limitation must be for a legitimate reason and must be proportionate. time-bound, non-discriminatory, and lawful. Avoid as far as possible the use of criminal laws to slow the spread of the epidemic. I have read how in some parliaments there have been projects put forth to penalize, to criminalize people who have breached the quarantine. And evidently that is something that cannot be accepted. Number 3, proactively communicate what is known, what is unknown, and what is being done to get more information. Information during emergencies is critical. Who is doing that job? Who is providing information to the population? If it's the regular press conferences that we see almost on every country at the moment, I hope and really emphasize the need for those conferences to provide regular and reliable information with engagement with the public. Make sure that people can ask questions, make sure that people can be, of course, be there. Number 4, explore how state social protection mechanisms, including nutrition support, income replacement, and housing provisions can be extended to informal sector workers and the unemployed. Here's where we need the alliances with civil society. Here's where we need the private sector. Here's where we need the faith-based community to meet the basic needs of the most marginalized communities. Food is what is making many people come out of their quarantine in many countries. 5, work to prevent and address stigmatizing views or attitudes in healthcare settings. I apologize, I didn't realize I left my computer with this messages coming through. I will just shut it down. I'm really sorry, but I cannot continue with this noise. I hope that I was able to do away with it. Number 5, work to prevent and stress stigmatizing views or attitudes in healthcare settings. There should be zero tolerance for discriminatory treatment of those who have acquired the novel coronavirus, people living with HIV, and members of key population communities. In any epidemic, discrimination in the provision of care or refusal to treat not only denies a person critical healthcare services, but also undermines the overall response. We need everybody who needs treatment. We need everybody who needs to be tested. Otherwise, we're not going to be able to stop the spread of COVID. Number 6, speak about the epidemic, its modes of transmission, and people who have the virus in a way that makes people feel empowered and willing to be tested, to self-isolate, or to provide help to others in need. These are messages that have gone out to youth. Please protect the elders. Don't go out. Stay at home. Number 7, take steps to reduce the likelihood of transmission in prisons, including reducing overcrowding through releasing non-dangerous prisoners and reviewing pretrial detention cases. This is something that several countries have done already. Number 8, meet people where they are. Ensure continuing access to health services and medicines, including providing multi-month prescriptions for medication, and continued resourcing for people-centered services for people who are most vulnerable. In some countries, I have seen that multi-month dispensing has been approved for the elderly, and in order to avoid them coming to the hospital to pick up their medications, they have designed appropriate mechanisms for family members to come and pick up their medicines. So we need to think out of the box in order to make sure that we protect those who are most vulnerable. Those were messages for government, but I have also some messages for civil society. Demand a say in the planning of the COVID response, ensuring all at-risk communities in the context of COVID-19 and otherwise vulnerable populations are represented. Monitor the response from the ground. Are you aware of whether the social protection programs are reaching out to your communities, your neighborhood, your own place? Monitoring how the response goes from the ground will ensure that human rights continue to be promoted and protected. Demand access to transparent and accurate information, as well as access to government officials in order to keep an open dialogue and report concerns. Reporting concerns, it's very, very important. And denounce also if there are acts of corruption taking place that you are aware of. Work with local key population groups, including LGBTI communities, sex workers, prisoners, homeless people, and people who use drugs. Support communities that may be afraid to access healthcare services because of stigma and discrimination to ensure that they have access to healthcare and appropriate services. I have seen some community organizations generating sheltered spaces where people who live in the streets or others that I have mentioned have been able to move in, and services then can be provided in those shelters. Disseminate information in appropriate modes, taking into account people's literacy, internet access, and language barriers. Not everybody has internet. Very beautiful information pieces have been circulated in the internet, but they may not necessarily target everyone. Advocate for national social protection schemes for workers in the informal sector. This is something I highlighted earlier in another slide. Informal sector, the bigger the informal sector it is, the more difficult it is for people to stay put in place. People will need to go out and look for the daily bread. Number 7, advocate and innovate to ensure treatment and care services are delivered. Be sure to place emphasis on mental health support and community connections. Be visible and vocal about ensuring that HIV response gains are not lost because of COVID-19. I also have some messages for people living with HIV. Remain up to date with the latest public health recommendations and regulations. Take your HIV medicine every day as prescribed and employ all other strategies to stay safe. Check that you know how to reach your local network of people living with HIV by electronic means. Make a plan for telephone and social media connections as public health measures. Respond to surveys. And here it's I will underscore that from UNAIDS and from other UN agencies, we have launched some surveys, as well as civil society have launched surveys to give feedback about your experiences and challenges. We need to know whether some of the social protection measures that we have supported ourselves or through government are being effective. This is critical. We need to understand the nature of your challenges to come up with alternative solutions if the ones that we have provided have not worked. Ensure that you have a supply of your necessary medical supplies on hand, ideally for 30 days or more. And in terms of HIV, as I mentioned before, a minimum of 3 months worth of medicines should have been provided to you in the last visit. Know how to access treatment and other supports within your community. Be on guard for rights violations of yourself and others. Public health measures do not extinguish your human rights. Now, let me underscore that. Public health measures do not extinguish your human rights. And not all countries have implemented policies to allow for longer prescriptions, for sure, but be in touch with your healthcare provider as early as possible. I think that I have walked you through a number of recommendations and guidelines on how to go through, some of them through government, some of them to communities, and of course to people living with HIV. There's a lot more that we can continue discussing through the Q&A. And let me just say that HIV stakeholders bring to this experience, again, almost 40 years worth of wisdom in responding to the epidemic. And I close with a reminder that the 1990 targets have not been put on hold because of COVID-19. We must work together to not only ensure that gains are not lost, but that we step up the pace. UNAIDS is moving forward with the global AIDS monitoring process and with support to countries to ensure prevention, treatment, and human rights goals are not sacrificed in 2020. I thank you for the time.
Thank you so much, Dr. Nunez. I think that presentation really emphasized what we well know in the HIV response, that this is a multidisciplinary effort. It's not just about treatment. It's not just about income. It's not just about food. It's not just about human rights. There's so many balls that we have to juggle at the moment, and we need to make sure we're working together to get it right. I'd like to hand over now to Ivan Cruikshank, who is going to talk about community service delivery in the context of this challenge. Ivan, over to you.
Thank you very much, Cedric, and I want to welcome the persons online. I'm very excited to be part of this conversation and to share a little bit about the experience from the community or civil society perspective in respect to how we are trying to address COVID-19 HIV responses. So I title my presentation, The Challenge of Delivering HIV Service in the Context of COVID-19. All right, so what I'm going to try and do, and I think most of us would know some of these, share a little bit about the context within which we're operating, some of the impact of the COVID on key populations and civil societies. We want to explore a little bit of the needs that we have identified from a number of the assessments that we have done, share with you some of the community responses and innovations that we're seeing on the ground, but importantly, we want to share some lessons that we have identified so far that can be used in the future. So what is the context in which we're operating? So COVID has presented us with a newness and a set of uncertainties that we're not familiar with. Many of us working in civil society, this is a totally new ball game. And so that is a challenge in and of itself. We have also been working in a context in which the health systems, because of this uncertainty and this newness of COVID, has had to refocus a lot of its energies to address the emerging challenges faced in terms of responding directly to COVID-19. But we're talking about a set of populations which have a long history of marginalization, oftentimes historically left out of health, social, economic development and interventions of government, with high levels of inequality and high levels of stigma associated with them. And this is, of course, compounded by the fact that there are stay-at-home and physical distancing orders and policies which have significant impact for the communities themselves, as well as the work of civil society, trying to respond to the needs of these key population groups. One of the things that we have discovered is that the COVID-19 pandemic does leave many key population groups without the adequate tools to be able to take control of their sexual health and rights. And that's a major challenge which civil society organizations have had to try and respond to. Another issue that faces relates to the negative impact that all of this is having on key population service delivery. So I think my colleague previously shared around the issue around stigma and discrimination, some issues around exclusion, neglect, and other human rights abuses which are emerging under COVID, which simply exacerbate what was a challenge for key population groups as well. And one of the things that we have discovered from the stay-at-home orders that have been in place, they really, if they're implemented inflexibly, they really have the potential to affect a number of our key population groups more. So our sex workers, our homeless MSM, our transgender population really are indicating that there is a significant impact of the operations of these stay-at-home orders and curfew rules on these particular populations. So I want to talk a little bit about 4 sets of impact that for us, I throw up some needs that we need to respond to, but also I will share a little later on how we are responding to these needs as civil society. And the needs are around the social and the psychosocial elements, some of which my colleague before mentioned, the economic and financial aspect, the human rights and segment discrimination aspect, and some programmatic and operational issues which civil society organizations do face in response to the challenge of COVID. So what are some of the social impacts? A lot of people are anxious about the pandemic and their own personal vulnerability. And I think that goes across the populations in general. They're not unique to key population groups, but somehow we think they're heightened when it comes on to the key population groups. That is, add to that, there's a high level of fear among CSO staff around the work that they're doing and engaging with the key populations and key population groups having fear about going to get service. So simple things like traveling on the bus to get service is a big concern for key population groups. And so these are real challenges that would impact the delivery of service to our key population groups. Then there's the issue around disruption in community cohesion. For a lot of our communities, the work that CSOs do and their ability to come together is a community cohesion point. And that has been disrupted. So many of them now are isolated, they're at home. And so what we're seeing is the side effects of isolation and quarantine leading to some mental health issues that we have had to be responding to. And I want to say that for a number of the key population groups, coming outside is a safe space. So their homes are not safe because of issues around stigma and discrimination. So coming outside and being able to engage outside of the home is their safe conduit. And so the stay-at-home rules and the curfew rules are really posing a significant challenge for many of our populations. The other area that we have identified is in the area of the loss of livelihood for a number of our populations. Many of the people who we are responding to their needs are people who are informal workers, and in many instances, people who work in some of the service industries like the hotel industries, the hotel industry, the fast food industry, many of which we know based on our own experiences, just seeing what's happening on the ground, have been significantly impacted by COVID. And so the loss of livelihood and fewer employment opportunities is posing a major challenge for our key population groups and challenging our own civil society response to those needs. At the level of the civil society, we are seeing some increased costs for some operational element of the work that we do. So we have had to be, and a number of the CSOs have had to be looking at investing more money in terms of IT and transporting their staff to facilitate some element of work from home and to provide some type of virtual service to the populations that we are trying to respond to their needs. And then we have the issues around human rights. We have reviewed most of the disaster management rules that have been implemented across the region. And while we accept the need for abrogation of rights, what we have seen is that for some of our populations, the abrogation of rights becomes even much more challenging. So we think about our sex work population, who many of them would work out of bars, would work on the street, would work in various locations that are now closed as a consequence of these new rules. And so that becomes a significant challenge. And even if they attempt to do some amount of work, the curfew rules and the penalties associated with some of these curfew rules create significant challenge for them. And I think Cesar really identified one of the challenges that we have seen is the overreach by our security forces as they attempt to implement some of these new rules that have come in place in response to COVID. Another area that we're seeing some challenge relates to the increased incidence of gender-based violence and intimate partner violence, just from people being at home. One story, that was shared by one of the organizations with us is that even for some of the women who get care packages from them, the fact that they take care packages home to them is creating a problem for intimate partner violence, where the male partner then becomes concerned about the fact that the organizations are bringing packages to them and therefore exposing them, the family, to community ridicule, and there's violence that is meted out to the woman. And in some instances, they've asked us to stop delivering the packages because of fear of that violence. And we continue to have instances of discrimination, including unintended disclosures during the lockdown period. One area that we have also found that we have had some challenge in is the crowding out of a lot of our key advocacy messaging, because at this point, a lot of the messages around is around COVID, and so putting forward our messaging around prevention as well as around human rights get lost in the conversation around COVID. And that's something that we are looking at and seeing how we can navigate that in a way that give us some more traction than might be possible in the context of COVID. And then there's some program delivery issues that CSOs have to grapple with. We have had to cut back our face-to-face service delivery mode. We have had to adjust our program priorities. We have had to delay or cancel some interventions which we thought were important and are in keeping with our strategic planning processes because of COVID. And then there's an inability to quickly connect with and mobilize the community, because you can't just call a meeting and people show up. And so it is much more difficult to engage with the communities around the issues that matter. And for a lot of the CSOs, there's limited ability to work remotely or to access tools and resources that can support their daily operations. So that's a major challenge for the organizations that are responding to key population issues. I highlight here just some of the challenges facing the PLHIV community, some of which we have heard before: concerns regarding availability of medicines and drug delivery, and the fear of being lost to follow-up. The ongoing concern around access to health services in the public health system. In fact, in some countries, and in one country in particular, we have heard of the numbers being reduced to about 50% of people who just show up. So your traditional walk-into facility has declined significantly, and so that is a significant issue as it relates to the type of service that would be available to our key population groups. And of course, our key population groups are concerned about personal protective equipment and their ability to be able to utilize those even where they're going for services. And it's not only PPEs, but also supplies such as alcohol and hand sanitizers, and the need for those to be available to them. So as I said before, our sex work and trans communities are hardest hit, and there are so many stories that we have picked up from those communities because of the significant impact that the curfews and the stay-at-home rules have had on these two populations. So we have identified a core set of needs that we have to respond to immediately, some of which were highlighted earlier on. So we have to now move to strengthen our nutritional and livelihood support. We have to try and address issues around IT and support that for remote working and remote engagement. We have to put PPE in the mix of what we do. Psychosocial support to link COVID and HIV to address issues around mental health, gender-based violence, and anti-violence support, and continue our adherence support. These are important issues that continue to face us. And then we have to address the issue around accurate community information around COVID and the HIV response. But notwithstanding that, I think there is good news. A lot of our CSOs continue to work, and this is a poster from one of our NGOs that they have online, pretty much saying we're still open and we're serving. We're still open for business. We're still here for you. You can engage with us through whatever means that we have identified, but we're still here to serve you. And I think generally what we're seeing is that most, if not all of our CSOs continue to find creative ways of providing the services that key population groups really need in these times. And so when we look at the general set of services that we have seen, they're focused around 4 principal areas: service delivery, addressing issues of human rights and advocacy as they emerge, trying to mobilize the community using various tools and strategies, as well as providing ongoing communication, whether it is around COVID or general HIV issues on an ongoing basis. So the community-based organizations continue to try and find ways of doing what they have been doing. And one area that has emerged, which we have been paying a lot more attention to, and a number of community organizations are trying to deal with at this moment, is to get more information through participatory community-based research. So a lot of online surveys are being done to continuously update CSOs with what are the needs, what are the emerging priorities, what are the challenges, and how the CSOs need to adapt their programs to be able to respond to those needs. And so I can share with you some of the ways that we have been trying to engage the key populations and our CSO members around 4 critical areas. So in the area of treatment, we're seeing courier services being used to deliver ARTs or prescriptions to people living with HIV. Organizations have now moved to put in appointment systems at their facility so that they can continue to provide service but maintain the small numbers that are required by law, and to also minimize risk exposure for both the staff as well as the clients who use the service. We've seen an increase in the use of phone tracking to monitor patient adherence, and the provision of care packages and personal protective equipment to people living with HIV. And we have moved support groups to online, and we have facilitators and community partners who are actually making home visits just to check on people to ensure that they're adhering and they're keeping on top of their medication. In terms of community mobilization, the increased use of telephone hotlines and text messaging is being used. We have a lot more virtual meetings and education sessions. And what we have been doing is providing the members of the populations with phone credit to support online engagement and making sure that they're available to be able to participate in these online mechanisms that we're trying to implement. So in the area of prevention, a lot of prevention interventions have moved online whether through the social media platforms. An interesting one that I wanted to share with you is many of you would be familiar with the Don't Rush Challenge. And one of our CSOs, JAS, Jamaica AIDS Support for Life, has actually used the Don't Rush Challenge to promote safe commodities, safe sex commodities. So that's a very interesting one. And I think you guys can look at their Instagram page and you will see a very interesting use of the Don't Rush Challenge to promote condom use and the various different tools. We have moved to small group interventions of 5 or less. We also are seeing organizations using existing online sites such as dating sites to reach people and then to offline them with appointments. So we're using existing channels to begin the conversation and then to say, okay, once we've started the discussion, let's then take it offline where we can schedule some appointments with you. We've refocused our message to address COVID and mental health issues, and of course, continued provision of support for PPEs and sanitation to people who might need it as part of the prevention strategy. And for human rights, we are trying to engage virtually, whether it is with policymakers or key population groups around the issues that emerge. One of the things that has emerged is the need for civil society and KP groups to be more engaged in some of the rules, the setting of some of the rules that would affect the population at large. What we have found is that civil society has largely been left out of the rule setting, and so some of the challenges that we're facing are not being contemplated by those who are setting the rules. And so we have had to be refocusing some of our human rights responses to look at how COVID is impacting human rights in general. So I share a couple of photos around some of the interventions. So this is one entity, implementing a lot of the protective mechanisms before any service is delivered. This is a group engaging in a virtual conversation. So we have moved some of what would have been a meeting offline and we're engaging virtually. And then what you have is a collaboration to provide hotline service. So instead of all the entities developing their own hotline, what you have had is a merging of entities for one common hotline, and people would then share to gather the resources to support that hotline. So we have developed also some communication tools via video. And here we had, this was a virtual media launch by one of our partners. This is the first virtual media launch where they had an event that they needed to engage the media on, and they used the virtual approach to engaging the media, similar to what governments are now doing. And then we developed some videos that can support the communities around some of the issues around the psychosocial element, so that we can have those on an ongoing basis to share with the communities. And so as we reflect on the issues, the big question for us is, what is the way forward? And for us, we think that it is a whole new world. We identify the challenges, but we also believe that COVID-19 provides an opportunity for KPs and civil society to be able to rethink the work that we do and to engage differently about our processes and how we relate to the constituencies that we serve, as well as the decision makers. And so we have identified opportunities around advocacy and engagement. We have seen a number of opportunities around building solidarity among entities that used to work in silos, whether it is at the national level or at the regional level, or even among CSOs who did not work together before. We have found that this COVID experience has provided an opportunity for solidarity building. And then there's an issue around intersectional and cross-movement learning. We have been looking at work that has been done by the environmental groups. We've been looking at work that has been done by the human rights groups that are not related to HIV. And there's a lot of learning that, that is occurring during this particular point in time. And we're also looking not only at civil society work, but we're also looking at the private sector to see what sort of learnings we can get from them around how we can alter the way we do business and engage with the constituencies that we are concerned about. The engagement with the online platforms is very important, and it's an emerging opportunity, and we are looking that this may be one of the ways that we have to use moving forward. And we're also identifying opportunities for fundraising throughout this COVID experience. So it is not all doom and gloom for us. We're using it to identify significant opportunities that COVID-19 is presenting to us. And so we have identified a couple lessons that we think are important moving forward. One is that as civil society organizations and groups working with key populations, we need to remain agile and dynamic. So, you know, a lot of reflective work needs to be done, a lot of rethinking of what we do, a lot of, you know, changing of our thinking is required in this particular context. And importantly, we need to work with the key population groups to identify rapid response mechanisms to address the emerging needs as they come. And some of that we do through rapid assessments of the needs and related services of the key population groups. We need to identify and adapt to new ways of working. We've talked about that a lot, which is such as the online way of working. But we also think that this is an opportunity for us to be able to extend our mandate to begin to look more closely at risk and disaster. We've never really paid much attention, many of us have never really paid much attention to risk and disaster. And I think that's a major lesson that COVID is teaching us. And that, I think, culminates in the need for us to have resilient business continuity processes as civil society organizations if we're going to be able to meet the needs of our key population groups. So I think those are major lessons for us. We are harnessing those lessons and we're using them as we go along to try and respond to the needs of the populations and to adjust the service that we provide in light of COVID-19. Thank you very much.
Thank you so much, Ivan. You really emphasize that being a voice for the voiceless, being a watchdog is a full-time job, even more so in a crisis situation where we have to pay attention to some of the unexpected impacts. We have to shine a light on them and also really innovate on the spot to figure out how we respond to a new layer of vulnerability and new needs. So we appreciate that presentation, and we are now going to move into about 35 minutes of questions, answers, discussions. Again, we invite you to submit your questions. You'll notice a slot where you can type your question in, click submit, and we'll be able to pose them to Dr. Nunez and Mr. Cruikshank. We've had 2 poll questions thus far, one of them about treatment access for people living with HIV in your respective countries. 87% of you have said that, yeah, people living with HIV have been able to access treatment so far. What's more concerning is when we move to the issue of income and nutrition support. So 60% of people are saying, yes, people are able to access some support. Absolutely nobody, zero, indicated that it was adequate. So we know we're in a situation where people are dealing with hunger, where people are not able to pay bills, and it's just an added layer of stress, and that we are going to have to think through how we address as an HIV response. We have a third question up about the very important issue of human rights violations in the context of COVID-19. So we invite you to respond to that question. And I will move now to some of the questions that have already been posted. The first one from PANCAP Executive Director, Dr. Rosamond Adams. And he's saying, of course, we understand that we need to pay attention to continuity of care despite the pandemic. We can't be complacent about the challenge that COVID presents in our resource-limited settings, and especially with our large vulnerable populations. And so this is a question to Dr. Nunez. What is the UNAIDS strategy for ensuring that these countries are able to push for the 1990 targets despite these disruptions caused by COVID-19? Dr. Nunez? Dr. Nunez, can you unmute?
Sorry, I thought I was on. I appreciate the question. Thank you, Dr. Adams, for your commitment and of course for this question. This is something that we've been approached in several fora, and just as we said when back in 2011, I remember when we set the first target of 15 million people in treatment by 2015, and at the time that there were only 6 million people on treatment, and we were able to beat that deadline ahead of time. The argument is that we need to remain having targets. If we don't have targets, we sort of lose sight of where we need to go. Will we probably miss the target of 2020 of 1990? It may be, but we need to remain focused on achieving those goals, those targets. The cascades in the Caribbean are heterogeneous. Some countries are going or were doing better than others. I was dismayed to learn about a country that was postponing its 2020 targets of 1990 to 2025. I don't think that is the way to go. I think that we must remain focused. How do we go about that in terms of resources? Particularly now that COVID-19 is probably going to be the focus of it. I think that we need to again go back to how much we have learned from HIV and be there in terms of the laboratory services in most countries were probably set up using resources that were used for HIV. And those laboratories should continue operating, and if resources are being made available for supplies, in this case, detection of CD4 count or viral load, they should continue to be funded, hopefully through the resources that are coming in to fund for COVID, just like HIV money was used at the time back to do so. We have heard this morning about prevention. We have heard this morning about treatment, and we have heard this morning about staying alive. And those are the three 90s. The first 90 that is going to let us know how many people live with HIV. The second 90 that will let us know how many of those are receiving treatment. And the last one is how many of them are virally suppressed. I feel that in the Caribbean, with the regional plan that is in place, it may need to have some adjustments, but pushing forward with the resources that are available and the mobilization of additional resources, we should stay the course. And definitely UNAIDS will be there to identify other opportunities.
Thank you, Dr. Nunez. Any thoughts in particular about the financing question? We've heard from ECLAC making a case about the very unique vulnerabilities that Caribbean societies have given the hit to their tourism industry, given their existing vulnerabilities as small island developing states. Do you have any particular guidance on how we address the challenge of financing, where we already have limited fiscal space and countries are going to be even more strained?
I agree with the optimism that we are going to get out of this one, but it is going to be painful. And it is going to be painful not only for people living with HIV or for those of us working on HIV, but it is going to be painful for everyone. Because of what I said about the informality and the limited fiscal space already in the region, we're going to need these programs that ECLAC has been proposing for a while about debt forgiveness or reprogramming of some of the resources that are being made available. I believe that it is completely wrong for these new funds that are being set up, the Sustainable Development Fund or the Humanitarian Fund, to forego or provide limited resources for those countries that are labeled as middle income or upper middle income. I think that when we bring the conversation up in the different fora, we need to talk about the vulnerabilities. That is the word. Middle income countries do have a lot of inequities, and there are a lot of vulnerable people. At the moment, in terms of funding, Cedrian, we have the IFIs who are working with the governments, and this is where we need to have the seat for civil society so that there is a say there, and to reprogram the resources that have been made available to the countries even before COVID. I know the World Bank has started that conversation. The World Bank has put forth already some resources in the billions of dollars for countries to determine where they should go. And the social protection area is one that should be receiving some of those resources. And I'm talking about conditional cash transfers. Also unconditional cash transfers, particularly for poverty-targeted situations, family and child allowances, scholarship benefits and cash that some countries are already implementing. But these resources will have to come through loans. And there is very limited space to move around those. And to go back to my first comment, the debt forgiveness for many countries, not only in the Caribbean, will be essential. Let's not forget that we have the hurricane season also on the horizon, and as much as we have spoken about resilience, it will be even a worse time to be facing a natural disaster like what the hurricanes bring.
Thanks so much. Delcora Williams, who is the NAC director for Antigua and Barbuda, and she's also a nurse. She's raising an important point. She's saying that service providers have to maintain a certain degree of closeness, physical closeness, during counseling and testing. And she's saying that this is something that would have to be looked at because there are services that cannot be done virtually. So do we have any guidance from the panel in terms of some of the adjustments that need to be made in terms of delivering services, testing rooms? How do we ensure that they're safe for both the service providers and clients at this time? And it would be interesting, Ivan, to hear from a community perspective, and then maybe we could hear from Dr. Nunez about the healthcare systems, how they could address this challenge.
On? Okay, great. So thank you very much for that question. Yes, the issue around the safety of the of providers is a big issue at the level of the community, and one that most of the civil society organizations that are providing service has been grappling with. They have been grappling with. If you recall, one of the pictures that I showed was one organization's doing thermometer testing before and screening before persons were admitted into the facility. So what you have to do, and what CSOs have been doing, yes, they're scaling back what they're doing, but even where they have to continue to provide those type of close services, they're implementing the type of strict biomedical protocols that we would see in a regular health facility. So they have the N95 masks, the gowns in facilities where people are actually pulling blood. All of the gear that are in place in a facility, in a health facility, traditional health facility, would need to be made available for these civil society organizations to be able to continue to do the work that they do. Because yes, you're right, we can't stop delivering some of these services, but we have to make sure that we have our gowns, our masks, our gloves, in fact, in some instances, you would have seen the big glass protection screens that we have. And in some instances, you do have the issue where people actually have to engage. They have to complete a profile. They complete that profile, and that profile is then used to determine whether or not the service is accessed, and how they triage people based on the responses to those questions. So it is a real issue. It is a big issue and a concerning issue. They have limited that, though, in terms of outreach activities, because you have less control in an outreach setting. So they have limited a lot of that to the facility-based operations, where they have been able to exercise a good amount of control over the screening process to ensure the safety and well-being of the teams providing the service.
Thank you, Ivan. And Dr. Nunes, a word about health systems, public health systems. What should they be doing?
I think health systems, as every other area in life, will have to adapt themselves. COVID has shown us how the collection of samples has been, supported by these cabins that are apparently created around acrylic or plastic. That will depend on these resources that we have at hand. But I would have to agree with the person who asked the question that proper measures need to be put in place to protect not only the person taking the sample, but also it could be the other way around. In HIV, we have realized that the rights work both ways. When a surgeon wants to get an HIV test from you because you're going to have a hernia taken away, I would like to have his or her HIV test as well, because I may also be at risk. I know that there are differences in this, but the most challenging part, Ciprian, at the moment throughout the world has been the availability of PPE, or personal protection equipment. I think that health facilities are the ones who should be prioritizing having the most efficient ones, and I am convinced that the proper settings for isolation and counseling, as she was also pointing out, will be made available. I was telling my team the other day about staff meetings. Some of you may or may not know our office in Panama, but we meet. It's about 10 people meeting in a rather small conference room. We're not going to be able to do that when we go back. We need to keep the 2 meters separation until we're able to have either herd immunity or a vaccine. And a vaccine is not going to be around for a while. So I know this is not a conference about the health-specific issues, but those are the two targets in terms of COVID-19 that we should keep in mind. We're going to have to be very, very, very careful until after we have achieved herd immunity or we have had access to an effective vaccine. Thank you.
Okay, that's the perfect segue to a question from Desiree Edgehill from Guyana, because she's raising the point of how we address members of population communities who at this moment are fearful about accessing healthcare services because they don't want to contract COVID-19. Ivan, a question for you. How do we engage them to encourage them to do what needs to be done?
Yeah, thank you very much. That's a big challenge. There's a lot of fear and anxiety. One of the things that we have been doing and engaging is that we've just been trying to use, because we've actually been engaging with a number of psychologists to provide clarity of information. So I think that's the first thing. So we want to get the biomedical information right and the correct information out to allay some of the fears. Because I think there's a lot of misinformation and conspiracy theories that are out there. So our job is to get to people the correct information. If we know, particularly for people who are HIV positive, we need to be able to also indicate to them why it is important for them to continue to maintain their appointments, to engage with their medical facilities because of the challenges that are likely to arise should they not do so. So it's important for us to be able to engage from a biomedical side around those issues with very clear, crisp, precise communication to the population. So we really have to ratchet up our communication game. The second thing is to address the anxieties. Recognize that they exist, accept them, they're the real anxieties that people have, but talk them through those anxieties and help them to understand what they need to do differently, how can they do things differently, how can they protect themselves should they decide to go to the facility. So we have been saying to people, look, do not leave your house without having your personal protective equipment. Even if the country says you mustn't wear a mask, we have said to people, put on a mask. You can't go wrong with it because it is protecting you and protecting others. So that's what we have been saying. When you go to a facility, observe social distancing or physical distancing. So not because everybody else is crowding up, you need to take the precaution and stay away from that crowd. So we have been actually saying to our people, encouraging them to take the measures that we think can help to keep them safe. But we do so acknowledging the anxieties that they have and helping them through those anxieties. And in fact, we are saying to people in some instances, stop following social media sometimes, give it a break for a day, give it a break for a couple hours. Don't read every update on what the current status of the COVID response is in your country, because that just simply triggers the anxiety more. If you're in a quarantine zone, don't focus so much on the quarantine, but perhaps focus on something that is much more meditative, uplifting, and engaging, and find other people who you can talk to who have gone, who have experienced the facility, who have experienced the travel on the bus. Let them share with you what their own encounter has been and how they have managed it to make sure that they are kept safe. So these are the things that we have been doing and encouraging our key population groups to do. But we do recognize that it is a major concern among our key population groups, as well as our CSO partners, around the provision and access to service.
Thanks for that, Ivan. And, success in doing this, I think, really depends upon the reputation and the relationships that you've built beforehand so that they accept your messages, accept your advice, because there's really been a barrage of sometimes conflicting messages. So we really do have to leverage the relationships that we've built with community in order to be able to serve them at this time. We have a question from Haiti from Sylvie Boisseau, and she thanked both of the presenters and is asking, is there any common platform where civil society can share tools, lessons learned, documents, and best practices? So before I hand over, just to mention that one of the things UNAIDS Caribbean has collaborated with PANCAP and with CRN Plus on is a product where we're sending out updates, offering people resources along the lines of how do you communicate about this, how do you organize your advocacy, how do you strengthen your own base in terms of responding to the challenges before you. So that is one of the products that we're working on jointly. And let me throw it now out to our two panelists to respond. What is available for our civil society partners working on this challenge? Somebody is still muted.
All right. So yes. So I think one of the things that we have been doing, and it's not a platform. What we have been doing is that we have developed a survey tool, which has been shared in a number of countries with a number of our CSO partners. CVC is also working with the 3 regional entities, that is Carry Flags, CSWC, and UC Trans. And we have this weekly engagement where what these entities would do, as well as CVC, is that we would map what is happening at country level, and we meet on a weekly basis to put all of it together, and then to have a discussion about what are the needs, what are the issues, and how we might respond. So that is something that is ongoing. It relies on people providing information to the questionnaires that come in, but we don't have a platform per se where we actually say to civil society, go there and look. But if you look at the CVC website, you can see updates from time to time on what is happening across the region.
Thanks so much for that, Ivan. We have a question from Alexandria Wong. She's making the point that many of the calls for submissions for small grants have excluded middle-income countries. And with the impact of COVID-19 on all countries, is there any consideration to reviewing the content or the context of these calls for submissions? Dr. Nunez, you touched on this a bit. I wonder if you could share a little bit of insight into the advocacy, the strategy to ensure that our countries will have access to the funding that we clearly need.
Thank you, Cedrian. And this is a very, very good question. In the meetings that I have an opportunity to be at, I raise over and over the importance of changing the mindset in some of the funding institutions about this typology that was originally created to determine whether a country could repay a loan. That's what it was when the World Bank created the typology of low income, middle income, or high income. At the moment, it is being used for a lot of programs as a criteria to have access to resources. From the UNAIDS perspective, that is wrong. And what we are doing is to, and I encourage all who have a chance to sit down at this particular tables of decision making, that the level of income does not determine the capacity of a society to deal with COVID. This is the tyranny of the averages. GDP is not the best function to gauge whether a country deserves to receive additional resources or low interest resources. This has not been solved. This is an issue that I have discussed with some of the ministers of finance in the Caribbean, and as it was brought up earlier, ECLAC is a strong ally. I would not discount as an idea that either PANCAP or even the CARICOM, I know that they do have a strong relationship with ECLAC in the Caribbean to bring the issue of HIV. I know that they have discussed the issue generally in terms of the economies of the Caribbean and in terms of the limited fiscal space that exists. But this is like a cascade. If a country has access to these resources, then organizations applying for grants coming from middle-income countries will have more chances of obtaining them. UNAIDS recently made a call for the funders to increase resources available for health spending and social protection. As I said during my presentation, these are an essential part of the economic response to COVID-19. I know for a fact that the World Bank and Caribbean Development Bank are looking at this very carefully, and if you have not done it so far, I would reach out to them. I would even encourage CBC, if you haven't done that. This is a time of video conferencing, and it's you don't have to visit anybody in a different or a far apart city. Let's try to come up with a combined way. UNAIDS can certainly play a role, but we need to change the mindset that middle-income countries should not access resources because we have everything solved.
And Ivan, I think it would be great to get a perspective from community organizations. We have a similar question from Dolores Robinson, a Jamaican working in TNT. She's saying, how can CSOs access their own funding to help during COVID-19? What's the guidance to our community organizations who want to do the work but don't have the resources?
So one of the things, so I think those are very important issues. One of the things that we have been doing, is that we have been mapping resources that exist because we have seen the emergence of pots of resource available to COVID through the COVID response. And we have been in dialogue with a number of funders who have exhibited a level of flexibility to respond to COVID. So we are seeing some small grants that are coming through that it's not tied to income classification, but really are tied to the needs on the ground. And those where those come to our attention, we actually have been sharing them with our partners through our web portal or through our social media platforms and our newsletter. So that's something that I would recommend that CSOs do. They, just look at these entities that are actually like CVC and others, regional entities that actually put out stuff on their social media, because we do see stuff from that come out. And one of the things that we have been doing is we really have been engaging with our donors around the flexibilities that would allow some of these smaller entities and countries that might have a higher GDP to be able to access resources. So that's one of the big issues. The other thing that we're actually working on as well is we're looking to work at the global level with a number of partners around resources for communities. And that's something that we had started some work on just in February. And of course, that was curtailed by COVID. But I know that there is a meeting coming up later on this month, where one of the substantive conversations that we're going to be having is how do we engage non-traditional players to be able to support community responses, both for HIV, but now that COVID has emerged, one of the things that we have said is that we need to put responding to COVID as part of that conversation.
Thanks so much, Ivan. And we take our final question from Monique Holtuin. She's saying that we need to take into account what's happening with those people who don't have access to social media. And Ivan and Dr. Nunes both raised this as a challenge. So her question is, how do we continue physical distancing and adapt it for the kind of face-to-face outreach that is still necessary to ensure we don't leave people behind? She's talking about issues like dispensing condoms, offering HIV testing. Any further insight into how we nail those challenges? And, you know, particularly for places like Suriname and Guyana, where we're also dealing with some very remote communities. They have a challenge that we don't have in some of the other countries. Any final insight before we leave, Ivan, on how we meet those challenges?
I would want to start by saying that we need to make sure that outreach officers have personal protective gear that can support them. And we also need to try and identify some personal protective mechanisms that can support the client as well. So without those, I would say we need to limit as much as possible those interventions. It's a challenge. I know prevention is one area that we have scaled back a lot of our work in because it involves a lot of outreach work. But where it is being done, what we have been seeing, particularly when it is being done offline, is that we have said to entities, we have said to individuals, look, we will provide, you will help to support you, we will help you to identify PPE that you can actually use to get your staff to go out to do the work in a way that protects them. And a number of entities have been able to, by partnership with private companies, I must say, get personal protective equipment and are using those to continue to do limited outreach interventions. But that's a big challenge, and I'd say that without the PPEs, that's something that we need to be very, very cautious about.
And we have one comment from Desiree Edgehill, who's saying that in Guyana, one of the strategies they've been using is dropping off condoms and lubes at KP-friendly spots, so clients can just pick them up and there's not as much need for one-on-one face-to-face interaction. So we're going to close off today's webinar with a look at the results of our final poll. We've asked whether vulnerable and marginalized communities in your country have been experiencing rights abuses in the context of COVID, and half of the respondents have said yes, 50% on the dot. I think it's very interesting that 36% of people have responded that they're not sure. And I think that that indicates that this is maybe something we have not been paying as much attention to as we should. I think one of our next steps as we move forward from this point is to really scale up our efforts around being watchdogs and ensuring that rights are not undermined, notwithstanding the necessary limitations that are part of the public health response. I think our presenters have also made very strong points about the challenge around funding, but not just the fact that we have a long road ahead of us, but that there are opportunities for advocacy, there are opportunities for innovation. And for the third point, I think I will take the issue raised by our friend Sylvie from Haiti, that we all really do have to collaborate in terms of sharing information, sharing best practices, and maybe collaborating on ensuring that there is a solid resource base that all of our partners could come to get the information they need to inform the work that they're doing at the moment. On that note, I will hand over to Dr. Singh to close us off.
Thank you so very much, Cedrian, for facilitating this webinar. Let me join you in thanking our presenters, Dr. Cesar Nunes from UNAIDS and Mr. Ivan Cruikshank from the Caribbean Vulnerable Communities Coalition. Thank you both for sharing your knowledge. I know that it is a really busy time for everyone, and so we are extremely grateful your investment in this webinar. Colleagues, we must continue our HIV service delivery at this time to everyone, but let's be vigilant to ensure that no one is left behind. Let's pay particular attention to the vulnerable, unmarginalized, and key population groups. On behalf of Dr. Rosamond Adams, PANCAP Director, thanks to UNAIDS PAHO, the Caribbean Vulnerable Communities Coalition, for collaborating with PANCAP on this webinar. Like Cedrian, I'll borrow from our colleague Sylvie from Haiti to say, let's continue to collaborate and share lessons learned and experiences in relation to COVID and HIV. In that regard, the PANCAP Communication Unit has made a call for success stories on COVID-19 and HIV. Please do submit your stories to us. These will be shared in the May edition of PANCAP newsletter for our stakeholders across the region. Colleagues, please do stay tuned. We will continue to share on COVID-19 and HIV. Our next webinar will focus on HIV prevention services in the context of COVID-19. Thank you all very much again for joining us for this webinar, and continue to follow us, PANCAP, UNAIDS, PAHO, and all of our technical partners as we share knowledge and experiences on COVID-19 and HIV. Have a good day, everyone.